We're jumping right into breaking down those complex systemic overlaps into clear, undeniable decision points for Step 2 CK. We're going to establish the exact exposure to management logic for urogenital, perinatal, dermatologic, and ophthalmic presentations. Okay, let's dive into this. Here's our mental roadmap for the 4 rapid-fire systems we are about to decode. 1. Urogenital and gynecologic conditions. 2. Perinatal and congenital infections. 3. Dermatologic lesions and soft tissue. And finally, 4. Ophthalmic and otic infections. Section 1. Urogenital and gynecologic conditions. So, prepubertal vaginal bleeding. This is a classic Step 2 CK presentation, and it sorts cleanly based on completely objective physical exam findings. Now, evaluating these patients often requires placing them in a knee-chest position just to properly visualize the vaginal vault. If it's trauma, you'll typically see localized labial bruising or superficial abrasions. But if you identify a malodorous vaginal discharge without any signs of trauma, the highest likelihood is a retained foreign body. And honestly, simple toilet paper is the most common culprit in this age group. First-line management here is just flushing the area with warm fluid irrigation before you even think about attempting any instrumentation. Now, if you see well-demarcated beefy red perineal erythema, you really need to suspect a group A streptococcus infection. On the more severe end, malignancies, specifically sarcoma bodiotes, which is a variant of rhabdomyosarcoma, present ominously as these soft, grape-like nodular masses protruding right through the vaginal introitus. Finally, if bleeding is accompanied by early breast development or pubic hair before the age of 8, well, your diagnostic pathway shifts entirely. Now you're working up precocious puberty. Moving on to cervical cancer screening guidelines. These are rigid, and understanding the physiological rationale behind them is absolutely crucial for the boards. Look, for any patient under the age of 21, absolutely no screening is indicated, period. And that's regardless of when they started having sex. Why? Because HPV infections in this young age group have an incredibly high rate of spontaneous clearance, and progressing to cervical cancer is just exceedingly rare. Now, from age 21 to 29, the standard of care is cytology, your basic pap smear, every 3 years. Once they hit 30, up to age 65, your options expand. You can either continue cytology every 3 years, perform co-testing with both cytology and HPV every 5 years, or just utilize primary HPV testing alone every 5 years. But here's the catch. You have to recognize the major exception to this timeline. For patients who are immunocompromised, like those who are HIV positive, screening protocols change entirely. For them, screening must begin right at the onset of sexual activity, completely bypassing that standard age 21 threshold. Let's decode the anatomical mechanisms driving varicocele. A primary varicocele typically presents right at puberty, it's left-sided, and it decompresses when the patient lies supine. This happens because of the nutcracker effect. The left renal vein gets compressed between the superior mesenteric artery and the aorta, which increases pressure in the left gonadal vein draining into it. And of course, incompetent venous valves just exacerbate that pooling. Conversely, a secondary varicocele presents prepubertally and it's right-sided. Because the right gonadal vein drains directly into the inferior vena cava, it completely bypasses that SMA-aorta junction. So the crucial point is that a right-sided mass persisting when the patient is supine is a massive clinical red flag. It strongly suggests a mechanical obstruction, demanding an immediate abdominal ultrasound to rule out a retroperitoneal mass like a Wilms tumor or renal cell carcinoma or an IVC thrombosis. And this brilliantly illustrates how a patent processus vaginalis leads directly to a communicating hydrocele. During fetal development, the testes descend through the inguinal canal, dragging a peritoneal outpouching along with them. If this fails to obliterate, it creates a direct open pathway from the abdominal cavity, allowing peritoneal fluid to literally pool down into the tunica vaginalis. Because of this communication, the hydrocele will predictably change in size. It'll often enlarge with crying or straining and decrease when the patient lies supine. From a management perspective, it's good news. Most communicating hydroceles in infants will actually resolve spontaneously as that processus vaginalis closes up by age 1. So observation is your initial step. But if the hydrocele persists beyond the first year of life, then surgical intervention is required to correct the defect and stop the development of an indirect inguinal hernia. Section 2. Perinatal and congenital infections. Let's talk about managing RHLO immunization. It requires precise timing and testing. For Rh-negative patients carrying an Rh-positive or unknown blood type fetus, prophylactic anti-D immune globulin is a must. It prevents the maternal immune system from developing permanent antibodies. You give this routinely at 28 to 32 weeks gestation, and again within 72 hours postpartum if the infant is confirmed Rh positive. But you also have to administer it following any event that risks fetal-maternal hemorrhage. We're talking ectopic pregnancies, threatened abortions, abdominal trauma, or an external cephalic version. The diagnostic sequence here is highly tested. If you suspect a massive fetal-maternal hemorrhage, you first perform a qualitative screen using the Rosette test. If that Rosette test comes back positive, you must follow up with a quantitative Kleihauer-Betke test or flow cytometry. These tests tell you the exact percentage of fetal red blood cells floating around in the maternal circulation, which lets you calculate the precise weight-based dose of anti-D immune globulin needed to neutralize the exposure. Now, managing a patient with a history of herpes simplex virus during pregnancy follows a very strict logic tree. Step 1. If there's a prior HSV infection, you start antiviral suppression, typically acyclovir or valacyclovir, at 36 weeks of gestation. Step 2. When the onset of labor begins, you absolutely must explicitly check the patient for active lesions or prodromal symptoms, things like burning or tingling. Step 3. The delivery method pivots right here. If the physical exam and history are totally clear, you can proceed with a normal vaginal delivery. However, if active lesions or a prodrome are present, especially if the membranes have ruptured, you must move straight to an urgent cesarean delivery. That is the definitive next best step to prevent a catastrophic neonatal herpes meningoencephalitis.
Now, what's really interesting about this slide is how it anchors you to the exact clinical keywords you need to separate overlapping congenital infections on an exam. Zika, for example, presents with microcephaly and intracranial calcifications. But to separate cytomegalovirus from toxoplasmosis, you really have to look at the calcification pattern. CMV features periventricular calcifications, and it's the most common non-genetic cause of sensory neural hearing loss. Toxoplasmosis, on the other hand, presents with a classic triad: diffuse intracerebral calcifications, severe chorioretinitis, and hydrocephalus. Just keep in mind that for toxoplasmosis, the risk of maternal fetal transmission is highest in the 3rd trimester, but the neurologic severity for the fetus is actually worst if it's transmitted in the 1st trimester. Meanwhile, congenital syphilis is sorted by the presence of rhinorrhea, often called snuffles, abnormal long bones, and this desquamating maculopapular rash that heavily involves the palms and soles.
Managing HIV in pregnancy is all about balancing maternal viral suppression with strict neonatal prophylaxis. Standard management involves maternal multi-drug ART for more than 6 weeks and completely avoiding breastfeeding in resource-rich settings. Basically, the maternal viral load dictates the entire delivery pathway. A cesarean delivery is mandated if the viral load is greater than 1,000 copies. But if that viral load is kept securely under 1,000, a vaginal delivery may be safely performed. On the neonatal side, management relies heavily on that exact same maternal viral load. If the maternal viral load is strictly controlled, meaning under 50 copies, the infant simply receives 4 weeks of prophylactic zidovudine. But if the maternal viral load is unsuppressed or even just unknown at the time of delivery, the infant is going to require a full empiric multi-drug ART regimen, typically combining zidovudine, lamivudine, and nevirapine.
Section 3. Dermalogic lesions and soft tissue.
When we evaluate cellulitis, identifying the deep risk factors that actually cause it is just as important as the acute treatment. Conditions like chronic edema, congestive heart failure, and post-surgical lymphedema fundamentally impair fluid dynamics and local immunity. Furthermore, even minor breaches in the skin barrier, like a simple tinea pedis dermatophyte infection between the toes, act as a major physical gateway. They allow bacteria direct access right into the dermis. Now, management diverges based on whether purulence is present. For non-purulent cellulitis, meaning it lacks fluctuance or drainable pus, your empiric coverage targets group A strep and MSSA using oral cephalexin or dicloxacillin. But if the cellulitis is purulent, you have to cover for MRSA. That requires targeted oral options like trimethoprim sulfamethoxazole, doxycycline, or clindamycin. Sorting the 4 types of Kaposi sarcoma depends entirely on distinct risk groups. First, it's extremely high yield to know that all 4 types are driven by human herpes virus 8, or HHV8. And on biopsy, they're all going to present with those characteristic spindle cells and neovascularization. The classic type is highly indolent, and it's seen primarily in older men of Mediterranean or Eastern European descent. Endemic KS is found in equatorial Africa and can actually present pretty aggressively in children. Iatrogenic KS strikes patients following organ transplantation because of heavy immunosuppression. Notably, this type often regresses if you can safely reduce that immunosuppression. Finally, AIDS-associated KS presents aggressively in advanced HIV patients, typically manifesting when the CD4 count drops below 200. Treating basal cell carcinoma follows various standardized surgical guidelines. First-line treatment is straightforward surgical excision with 4 mm margins. However, Mohs micrographic surgery is the go-to required intervention for any tumors located in high-risk areas, specifically the face, hands, feet, or genitals. It's also required for tumors with poorly defined clinical borders or signs of perineural involvement. Mohs is great because it allows for maximum tissue conservation while confirming clear margins microscopically. Second-line options like topical fluorouracil or imiqued are strictly reserved for low-risk, superficial tumors located on the trunk or extremities, specifically in patients where surgery is otherwise contraindicated.
Section 4. Ophthalmic and otic infections.
Choosing empiric antibiotics for bacterial meningitis completely relies on the patient's age and immune status. For ages 2 to 50, the standard is vancomycin plus a third-generation cephalosporin like ceftriaxone. But here is the big red flag. Anyone over the age of 50 carries a specific risk for Listeria monocytogenes, meaning you absolutely must add ampicillin to the regimen. Crucially, immunocompromised patients of any age also require the addition of ampicillin to cover Listeria. Another critical point, to prevent severe neurologic complications, specifically the sensory neural hearing loss associated with Streptococcus pneumonia, intravenous dexamethasone should be administered concurrently with or shortly before the very first dose of empiric antibiotics.
When an advanced HIV patient presents with vision loss, differentiating the etiology really comes down to two things: pain and the immune threshold. CMV retinitis is painless. It classically occurs only when the patient's CD4 count drops below 50. In stark contrast, HSV and vis-a-vis retinitis, which manifest as acute retinal necrosis syndrome, are acutely painful. They can occur at much higher CD4 levels, and they present with peripheral pale lesions accompanied by central retinal necrosis. For CMV retinitis, standard systemic antivirals might not be enough for severe vision-threatening disease involving the macula. Those cases specifically require direct intravitreal injections of ganciclovir.
Take a look at this. Notice the characteristic painless, perivascular, fluffy, yellow-white areas of retinal necrosis. These lesions aggressively track right along the vascular distribution, and they're frequently mixed with thick areas of retinal hemorrhage. This creates what's classically described as a pizza pie appearance on a fundoscopic exam. Recognizing this distinct visual pattern instantaneously confirms severe CMV retinitis in an advanced HIV patient, dictating an immediate step toward both systemic and intravitreal antiviral therapies. Diagnosing acute otitis media requires identifying a bulging tympanic membrane paired with definitively decreased mobility on pneumatic otoscopy. The initial step in management is a 10-day course of high-dose amoxicillin. But if the patient fails to improve on this therapy within a month, it strongly signals the presence of beta-lactamase-producing strains, like non-typable Haemophilus influenzae or Moraxella catarrhalis. At that point, the mandated next step is a switch to amoxicillin clavulinate. If the patient subsequently fails the amoxicillin clavulinate regimen, then tympanocentesis or a switch to intramuscular ceftriaxone is indicated. To do a compact exposure to management recap: prepubertal bleeding without trauma points straight to foreign bodies, right-sided prepubertal varicoceles bypass normal venous anatomy and require an immediate ultrasound. In pregnancy, active HSV lesions dictate a cesarean delivery, and viral loads above 1,000 mandate the same for HIV. A painless visual lesion in an HIV patient points towards CMV, while painful presentations align with HSV. Tinea pedis serves as an open door for cellulitis, and an age over 50 demands ampicillin for meningitis. Master these hard clinical dividers and the differential diagnosis becomes crystal clear.